In this technical note, we present the Anatomic Biologic ACL primary repair technique, which employs biointegrative sutures and fixation to achieve a fully biologic repair of proximally torn ACLs. This approach promotes a biologic healing environment through biointegrated materials that balance mechanical strength and biodegradability, minimizing the synthetic burden and inflammatory responses. These are our disclosures. Here we are highlighting the indications and contraindications for our technique. To illustrate this technique, we will be looking at a 42-year-old female who injured her right knee skiing. Looking at the sagittal and coronal views of the preoperative MRI, the patient appears to have a proximal tear of the ACL with apparent good tissue quality remaining. Moving into the knee through the anterolateral portal, we begin by confirming the findings on the MRI. A proximal tear of the ACL with excellent tissue quality can be seen. A small notchplasty is performed for better viewing and to induce a healing response. Next, using a self-retrieving suture passer, a number 2 active braid collagen co-braid suture is passed into the anteromedial bundle of the ACL in a Bunnell-type fashion, moving from as far distally as possible to the proximally avulsed end. It is important that proximally the repair sutures exit on either side of the ligament so that vertical traction can be created at the final suture anchor fixation. An accessory inframedial portal is created for suture management. The same suturing technique for the AM bundle was now repeated for the PL bundle using a striped number 2 active braid collagen co-braid suture. Again, we begin as far distally as possible, move to the proximally avulsed end of the ligament. Caution must be taken to avoid impacting the suture passer's needle into the wall. This can be done by changing the angle of your hand. We should monitor the resistance as the needle passes through the tissues to avoid transecting previously placed sutures. In contrast to the AM bundle sutures, the PL repair sutures both exit laterally towards the femoral wall to achieve traction towards the wall at final suture anchor fixation. Next, using the inframedial portal, with the knee at 115 degrees of flexion, a hole is punched and tapped for the PL bundle sutures at the native site of the PL bundle origin. With the knee remaining at 115 degrees of flexion, the PL bundle sutures are tensioned and anchored back into the native position using a 4.75 biointegrated osteofiber snare suture anchor. The suture anchor handle is removed, the core stitches are left in place, and the free ends of the PL repair sutures are then cut short. The core stitches of the PL anchor are then sequentially retrieved out of the AM portal and passed from lateral to medial through the proximal aspect of the PL bundle using the suture passer. These sutures are then retrieved and parked in the inframedial portal. The AM suture anchor is then loaded with a 2.5 mm active braid collagen co-braid tape, which will serve as the suture augmentation. With the knee at 90 degrees, we punch and tap the AM suture anchor hole into the native AM bundle footprint. The suture anchor, preloaded with tape, is then used to tension the AM bundle repair sutures and fix them. With the AM repair stitches cut short and the tapes retrieved out the inframedial portal, we now tie and compress the PL bundle compression stitches that were passed previously, which achieves maximal wall content and reestablishes the native anatomic ligament vector. These are then cut short. For the placement of the suture augmentation, a drill hole is created from the proximal anteromedial cortex of the tibia up and exiting into the anterior third of the tibial ACL insertion using a 2.4 mm cannulated pin. The suture augmentation is retrieved through the cannulated pin with the help of a nitinol wire lasso that is used to shuttle the active braid tape down through the tibia. The final step of the procedure is to lightly tension and fixate our suture augmentation distally. To end the procedure, we go back into the knee to ensure that there is no graft impingement and the knee has full range of motion. Finally, the knee is taken through a range of motion and a Lockman exam is performed to confirm stability. Here we are highlighting some important pitfalls and pearls to consider to avoid complications during the procedure. And finally, here we are presenting a brief overview of some of the highlights of our milestone-based rehabilitation approach. This was our technical notes video, which employs biointegrative sutures and fixation to achieve a fully biologic repair of proximally torn ACLs. Thank you for your attention.